Hello everyone, welcome back to Axon Health. Today I wanted to talk about the transition periods during a treatment plan. What to expect if you're basically seeing someone who's going to provide a full spectrum of treatment going from passive to active care. Different conditions will hold different time frames for this. But what we do know in the literature, whether it's chiropractic, rehab, or so on forth, is that going from a passive care, which means that it's passive, you're not doing much, whether that's, PNF stretching, propioneuromuscular stretching, or neurofacilitation stretching, or scraping or grafting or cupping or any of those types of things, spinal manipulation, and then moving towards somewhere where you're having more of an active care approach, which means you're doing it, probably yields the best results. So the days of strictly spinal manipulation, in my opinion, are coming to an end. This is not to say that spinal manipulation doesn't have great benefits for acute, chronic, or low back pain. There's a lot of great research, but I always tell this to people. If you are adjusting someone's low back, now it's different for everything. Let's say someone comes in with a very acute injury, their quadracea lumborum or their lower back muscles, their rector spinae are completely spasmed. You see them a couple days in a row and you add some spinal manipulation, you're more in the passive care. Maybe you do some ice or heat modalities, maybe you do some e-stim, maybe you do some grafting, some soft tissue release. This has a lot of great benefit in that acute phase, but what you want to be doing is transitioning from a passive, like I said, to a more active. So what I always say is, you can get spinal manipulation as much as you want, but if you have no core stability, if you can't do a dead bug or any of those other very simple rehab exercises for your low back, your core musculature that's given by physical therapists or chiropractors, the chances are you're probably not doing the most optimal thing to keep you out of pain for a long period of time. You hear a lot of people that will say, oh, I've been going to the chiropractor, once a month or something forever. It has nothing to do with if that's beneficial or not, because it does come down to patient preference once the acute care of treatment is gone. But what really happens is that patient learning things on their own? And active care is, obviously it takes the most work because it's coming from the patient. And people like to have things done for them. So I know grafting feels good, or cupping and stuff like that. And that can do a lot of great things. There is research to support all of it. But the thing is, if you're not doing things on your own, if you're not exercising and stabilizing, the chances are those effects that you're seeing are not going to get you where you want. I heard someone in the gym talking about today that the person they were seeing, I'm not going to say what type of provider it was doing a lot of dry needling, and they were seeing great results, but they weren't really getting to where they wanted to be. And this is because that person had no stability. They couldn't keep their scapulas packed in the overhead position. I've seen a lot of these people train in the gym. I watch the way people train. I look at their mechanics, and a lot of people who think they have good form actually don't have as optimal form as they could have if they added some sort of prehab or rehab type exercises into the routine. Now, one thing I had to learn when I was in school was I approached everything from a hypertrophy versus strength, a body, changing the way you look compared to actually rehabbing or pre-rehab to keep yourself from actually getting injured. And those are two different things. There is some overlap, but in order to say, come out of an acute low back injury. That's the one I always like to use. And like I said, muscle spasm, you're locked up. Yes, in the beginning, more than likely, you're not going to be able to complete some of the more active stuff because you're in a lot of pain, you're spasms. So like I said, spinal manipulation or drop tables, working into maybe some grafting and myofascial release, ice, heat, and e-stim, but moving your way throughout maybe so 4 to 6 weeks is probably the acute recommendation for a treatment plan, 10 to 12 visits on the chiropractic side. It's probably somewhat similar on a physical therapy side, depending on, the injury, unless someone has like a full patellar tendon rupture, it would be a little bit longer than that. But throughout that transition, the passive care starts to go down and the active care starts to go up. And if the person that you're seeing is not, it's not to put anyone down, people like different things. Some people like going to the chiropractor, they like getting cracked, and they're on their way and they get benefit from that. But if you really want to see the benefits of long-term care, the provider you're seeing will want to include some active protocol once you're at the point that's deemed clinically necessary. So a great, the Evidence-Based Chiropractor is one of the best podcasts for chiropractic and physical therapy as well, because it also goes over a lot of rehab stuff. But, the sit to stand is such a very basic pattern that a lot of people can't do. So if someone is coming to see me and they're getting spinal manipulation maybe every other week or, 2 times a week, whatever it is they were seeing, but they can't properly perform a sit to stand, in my clinical experience and opinion and through anecdotal, just what I see, something is going on. If you can't do a proper squat, if you can't do a proper deadlift hinge, if you don't know how to activate muscles, if you don't know how to stabilize your core, if you don't know how to keep your scapula down and packed and your scapula is all loose like this, the chances are everything that you're getting is not going to be as optimal as if you were going to do something with the approach of active care. So this is why the benefit of exercise and stability is so important. Now again, rehab and pre-rehab, different than strength and hypertrophy. There is crossover, obviously, because you're still doing movement patterns, but the rehab research focuses a lot on isometrics, so static holds. This is an isometric right here. So eccentric, concentric, and the phase, I can never say it properly from RP, the amortization phase. So I just say moving the weight, but that's the proper way they say it. So, and it sounds a lot smarter. But working through those ranges, slower eccentrics, also good for rehab purposes, but there's a lot of good research on just isometric holds in the beginning where someone might be able to actually be able to do a full contraction or a full eccentric, maybe because of the type of the injury they have. So this is really important. Another thing that's good too is Dr. Don Murphy, who has the CRISP protocols, researcher for 30 years with low back pain and chronic neck pain, was seeing that, figuring out what's going on. And it's more than just spinal manipulation. So figuring out the direction of detriment, I believe they call it, which way causes the most pain, which way doesn't cause the most pain, and then working into the protocols that they've seen in the research in order to bring down. So, bringing people from peripheralization, pain that's going to the periphery, out to the fingers or toes, and bringing it back centrally. That's a great first step. So if, you have an acute injury or something like that, and you have pain down to your toes, and then bringing that back up to, say, maybe your knee or even your hip, and then all of a sudden it's now local, that's a step in the right direction. But I don't believe that's going to happen with the majority of people if you're just focusing on passive care. So I can tell you in the literature right now, one of the big mistakes that you see with, say, plantar fasciitis is people will scrape and do all that stuff, and then people will get relief, but they will never see the benefit of saying a full range single calf raise, something in my teeth, and go down in the eccentric. So actually working on stability and going through the full eccentric range of motion. That is going to be necessary in order to see the results that you want to see for some of these conditions. And again, this is nothing against Graston or scraping or cupping or spinal manipulation. They have great benefit, but in order to see the best research evidence right now and anecdotes is the person needs to have some active care. And the reason why people love cupping or they love Graston and they love tri-needling is because they see results, but they don't have to actually put in the full work to reach that 100% recovery. And no one is going to be able to hold your hand through that the whole way through. That's the one thing that comes about perception change and changing people's beliefs. Like everything in life, the patient needs to understand, and if they don't, that's on them, that in order to reach that optimal, care results, active cares needs to be implemented. So there are lots of chiropractors out there that just adjust. We call them straight chiropractors, and that's awesome. Nothing against them. It's not how my philosophy is, and I don't think the literature is hand in hand with that. And I think you have to be honest about that, because if you are a provider and you want to give the best care to your patients, telling them they don't need active care or telling them they don't need rehab protocols, you're doing your patients a disservice. That's nothing bad to say about you. They might not know the research. It's just this is what the research says, and this is for chiropractic, physical therapists, medical doctors, whatever it is. Medication is passive, and certain conditions need medication when the patient doesn't want to make lifestyle changes. But say someone who has high cholesterol and they put them on a statin, in order to potentially get them off a statin, they have to actively change their habits. They have to take control of their life, maybe log for 6 to 12 weeks, see what foods are maybe affecting their cholesterol, increase their cardiovascular activity, and increase their strength and resistance training. So it really comes down to this active protocol that a lot of people are not willing to do. And that's why medications are so high. And we need medications. Medications are not bad. You know, medications can be used, you know, in the wrong time and setting. So someone who sprains their ankle, grade 2 sprain, putting on an opiate, which people still do that. It's not what any guidelines show. You know, opiates and stuff like that are left for severe cancer patients or very, very extreme chronic pain that may be in the end stage of their lives. But you know, this is why this stuff is so popular. Again, dry needling, Graston cupping, medications. Again, nothing against any of them. Time and place for everything. But in order to get the full results that you're looking for, to finish off, active care is key. The Evidence-Based Chiropractor podcast this Monday, they come out with a podcast every Monday, talking about the sit to stand and the benefit of core stability. Super, super important. And that's just the way I see it. That's how I agree with the philosophy on, you know, moving from a passive to an active care, whether it's a acute or chronic pain patient. You know, no one should be getting the cookie cutter treatment plan. If you're seeing someone that's giving you a cookie cutter treatment plan, think about what you're doing. If you enjoy going to them, that's awesome. Patient preference, I always talk about that. If you enjoy it, go right ahead. But if you're looking for something more and you're not getting the relief you want to get, it might be time to take charge of your life and put in some active care. And that's the only way you're really going to change. You have to take charge of your own care. People can't do it for you forever. Thank you so much. Have a great day.